Yeah, so this is the business requirement. So what are we trying to do? Trying to measure, what's the purpose here? Cost of care PMPM, resource use PMPM. Providers be able to compare themselves to some kind of risk, to some kind of benchmark, risk adjusted. Purchasers can determine real cost, and then public transparency of cost and efficiency. Next slide. Health partners, I think I've told you about that. It's both it's an integrated system, both a health plan and hospital and own practices that are part of this. And they've developed this measure kind of in that context in Minnesota. It's been actually starting. It's NQF approved and being picked up by kind of other systems. And as I understand, Maine Health or NEAC is actually looking at this and thinking about using it as well. So, which is really great news. Okay, next slide. So what are the two measures? Total cost of care, which is going to include price and utilization, and there's going to be market-specific variation in this, which is really important. Okay, so it's not standardized cost. And then there's a companion resource use measure, which measures resource consumption across different areas: inpatient, outpatient, professional, and pharmacy, and puts them all on together on a linear scale. And so it basically does weighting across RVUs, DRGs, and so forth, weighting them all appropriately in relation to one another so you can get an overall measure of resource use. Okay? And for the total total resource use index. And then it's been reliably tested. It's actually been tested to be valid. It measures what it purports to measure, and it's NQF approved. Next slide. It's population-based. It's risk-adjusted for burden of illness. And one thing it really is when I see how it's being used in other settings, and I think this gets to Dennis's question, it really gives it provides a lot of opportunities to measure resource use for different activities, different clinical cohorts, and so forth. And these two measures together allow one to understand both the actual costs, which is really important from the plan sponsor point of view, but also the resource use about what's happening in overuse in care. So next slide. So what's the measure? The total cost index, and it is an index, but the first thing it does is it computes total PMPM as two parts. It computes the PMPM for the medical PMPM, and it computes the pharmacy PMPM. I think it's really obvious. Sometimes the eligibility is slightly different. Counts for that. It is going to risk adjust it using a risk score. The risk score that we are going to use is ERGs, and that can be a discussion in itself. It's episode based. It's not limited to age, gender, and diagnoses. Okay, but in the Health Partners material, they point out that the Society of Actuaries periodically tests all these risk adjustment models, and the main ones out in the market, whether it's Johns Hopkins or the Ingenix one or whatever, all do about the same. All right. So we can have a discussion about that if you want. The risk, you take the total PMPM, divide it by the risk score, and then to get the index, and I'm going to show you some examples of indexes in a minute, you take the risk-adjusted PMPM and divide it by the peer group risk-adjusted PMPM. Okay. Now we're going to come back to talk about what the peer group should be in a minute. It could be all the primary care people in Maine. It could be all the primary practices above Waterville, and another peer group could be all the primary practices below, and so forth. Okay. And actually, they do things kind of regionally that way in the Midwest, and some of the instances in the Midwest where they're using this thing. Okay? Next slide. I talked about this. Let's go to the next slide. And so the total resource use measure, rather than add up the costs, it adds up all the resources, all the RVUs, the DRG weights, and so forth, puts them on a scale. We can talk about how they do that if you want to. Does the same thing for pharmacy, and then there's a risk score, and this is exactly the same calculation. Okay? This measure is much like what we actually developed and did at Health Dialogue as standardized cost, and you guys have used. And we basically used the CMS weights and applied them uniformly across, kind of all providers, all claims, and came up with a standardized cost. And that measure is actually weighted utilization, and this is really weighted utilization, weighted by the intensity of the service, whether it's RVU, DRG weight, so forth.
I mean, it's analogous with the CMS has that geographical.
No, it's not the geographic multiplier. They have, let's talk about it later, but they have a way to do standardized cost based on, site of service, kind of what DRG it is and so forth. The risk score that we would use is the Symmetry and Genix risk score, which is based upon episodes of care plus age and gender, okay? Episodes of care are built based on diagnosis codes and procedures. So there is some risk, if you will, if somebody goes to a physician who's gives somebody a lot of services and they have a lot of inappropriate episodes, they would essentially get credit for that as a morbidity measure, right? And you would not get the separation between providers that you would hope to get to identify high utilizers and low utilizers. Is that, okay, everybody with me? That's the thought. We've actually asked that question directly to health partners and to get their input on it. They don't actually know what the implication of that is because they don't use it. They use ACGs from Hopkins, which are diagnosis-based. I don't know exactly how this is. I don't know the actual effect of that because I've never found anybody who's explicitly gone to the data and looked. There's clearly some potential there, but I think this risk score is driven mainly by diagnosis as opposed to procedures. Okay. And so this thing has been tested for years by health partners. And next slide. And they tested it two ways. They tested what happens if we measure practices year after year after year. How consistent are they? And it's hard to see it, but each 3 bars is a practice, and you can see it's actually fairly consistent as you would expect. Okay, these practices would not be greatly changing rank year after year, okay? Next slide. Then the other thing they did is they went in and said, well, what happens if we don't get the whole panel? And so they sampled the panel from the practices at least 3 times in this demonstration. So the question is, if you sample it once and compute this measure and sample it again and you get a slightly different sample of patients, and you sample it a 3rd time, are you going to get different measures? And this says you don't. You're going to rank the practices the same. And so that's important too. Okay? Next slide. So what comes out, and this is kind of where we would begin to get to the value assignment. You get indexes out. And so these are just numbers in this example. And let me just concentrate on the risk scores here. So if you were going to have regional benchmarks, you might report your risk scores like this, where these are the practice risk scores, and these are the risk scores of the peers. And the peer group is not 1, because the peer group may be Northern Maine as opposed to Southern Maine. If you want your peer group to be the entire primary care population, then these would tend to be 1. And I'm just showing you this example to show that there's different ways to do this. And really don't want to make this overly complex, but I kind of want you guys, I want everybody to understand what's behind it, because these are kind of the embedded assumptions. The total cost of care index, go to the next slide. Next slide. So the total cost of care index measures the practice total cost of care, right? It's the risk-adjusted PMPM to the peer group PMPM to get an index. And so this practice's PMPM risk-adjusted is lower than the peer groups. And it does the comparison year